Okay, so hello everyone. Our webinar will start now. So this is Maeve from Echo International Marketing Team. Before we get on to this webinar, I would like to express our sincere gratitude to our speakers for their willingness to share their expertise and their knowledge with us. And we sincerely thank all the participants for joining us today. And this webinar is organized by Echo Medical Company and regarding to their rich experience in the field of microwave ablation. It's our great pleasure to invite Professor Serkan from the Turkey and Professor Chung from Taiwan area to share their experience with us. And Professor Serkan Alibao is an associate professor of cardiovascular and interventional radiology. He has accumulated much microwave ablation experience to treat the blind breast lesions. A total of 58 articles have been published in medical literature, and with 45 of those indexed in SCI or SCI expanded journals. Additionally, there have been 125 presentations at the international congresses and also 45 presentations at the national congresses. And we have the second speaker, Professor Chung Guoten, is a director of Haifu Center of Taipei Chungsang Hospital. His specialties including laparoscopic microwave ablation, Haifu for the uterine fibroids, the transvaginal approach, including the myomectomy, and the hysteroscopic minimally invasive surgery. So on behalf of the CCMA and Echo Medical, I'd like to thank you all for joining us today. According to the course agenda today, Professor Serkan will give us a lecture first, followed by Professor Chung's presentation. And then we will have a discussion part. And this webinar will offer valuable information and perspectives. So we encourage you to actively engage in this discussion part and ask your questions in the chat box or open your microphone during the discussion part. And now let's welcome Professor Serkan to start his presentation first.
Okay, thank you. Let me share my presentation. Yeah.
Okay.
Okay, I think this was okay.
Yes.
Okay, thank you for a kind presentation for me. And I have to make a special thanks to my colleagues from Eco Microwave from both the global side and the Turkish side. And today I'm trying to express some microwave ablation treatments about the benign breast lesions. So if we look for the benign breast disease, we can easily classify it as three types of the lesion. One type, non-proliferative ones, we are very familiar since the simple cysts in every woman. And proliferative lesions with RATP and atypical hyperplasia is the third part of the benign breast diseases. In these proliferative lesions, fibroadenoma and sclerosing adenosis is the most popular lesions for us within the benign breast lesions. And if you see, we couldn't say easily it is already benign, but we cannot see a future breast cancer. So it's a small risk, but we have a risk of future breast cancer. And the most common symptoms is including a nipple discharge, mastalgia, and the gradual growth since the mass effect of these palpable lesions. If you look at large cohort study for the risk of the cancer for the benign breast lesion, it's about up to 10% of the women with benign breast lesion have malign breast lesion during their lifetime. So if we focus on the fibroadenoma, today's topic, most common solid mass in women of all ages, the incidence having increased over the past few decades since the breast cancer screening programs increase the detection of rate of the fibroadenomas, which is of course is related to about the screening technology or imaging technology with ultrasound or MRI. And most common signs, mobile, non-adherent, palpable mass with or without tender. The growth of fibroadenoma is usually slow. What is the typical imaging patterns or imaging features of fibroadenoma on mammography or ultrasound? Is similar almost. It is the oval or macrolobulated, circumscribed or well-defined lesions. It could be multiple or bilateral, and especially on mammography, we can see a popcorn shape, which is a benign calcifications, and we can have some dense or large heterogeneous calcifications within the lesion. And in ultrasound, it is a typical appearance parallel to skin surface, and the length-height ratio typically more than or over than 1.4. In Doppler imaging, peripheral feeding vessels can be seen on this imaging. On MRI, typically the on T2 weighted images, it has high signal intensity. If the patient is after menopause or a treatment, especially for the ablation treatment, it is important for us for this webinar. The T2 signal would be decreased in the MR image, and some false positive imaging results could be achieved on posterior emission tomography, and it's an other feature of the fibroadenoma. You can see a typical fibroadenoma with ultrasound on the left side and with MRI on the right side. It is high in signal intensity on T2 weighted image, and after contrast enhancement, after contrast injection, it enhanced brightly or heterogeneous brightly, and has some septas form or fibrous septa form within the lesion. And ultrasound imaging, you see it is parallel to skin surface and some peripheral or feeder vascularity, the peripheral of the lesion. And in MRI image, we also the diffusion on diffusion images, no diffusion restriction is seen for the typical fibroadenoma. How can we manage it? Small asymptomatic lesion and generally do not require treatment. It is written on the literature, but follow-up is necessary because, or since I described the first slides, we use ultrasound imaging in every 3 or 6 months. Routinely, we do it in 6 months period. Since it's the broad 3 lesions, so 2 years follow-up is needed for these lesions. If the lesion diameter increases by more than 20% within 6 months, it must be further management, and it develops a suspicious features. So we perform biopsy. By the way, we perform biopsy, I'll say it again, during the patient preparation or patient selection. We perform biopsy all the lesions before the ablation treatment. So when we treat it, if the lesion is large sized, if the patient have an anxiety with pain and cosmetic problems, and especially with an unsatisfied mood with the conservative management, the typical patient is the anxious ones with unsatisfied with the conservative management, actually, not large size, not palpable lesions, the anxious mood for the, although it is a small risk, but being developing a future breast cancer. So what are treatment options? We can use invasive treatment options. Of course, it's open surgery in the basic and the most common treatment options for the breast lesions, both for the benign and the malign lesion. And what is the minimal invasive options? The vacuum-assisted excisional biopsy and the ablation techniques for the benign breast lesions are optional and is ready for the market. So in radiofrequency ablation and microwave ablation, we do an electromagnetic action in technical. principle. And in HIFU, it is a mechanical action for the lesion, to ablate the lesion or to diminish the lesion. And in cryoablation, direct thermal action is the main technical principle for the ablation. If we look for the device market through the Europe area, you see for the last decades, note that the microwave ablation and the cryoablation has an increasing market share in ablation device market through the Europe, and you realize that a small part market share, but the definitive increase in the irreversible electroporation, and the other ones are stable or low, decreasing the market shares in its own. Of course, we have the dimension of ablation area. We achieve the ablation area related to our power and the time we applied. So the technical parameters and technical principles for the microablation is the high power and high time is equals the high ablation area. And what is the advantages for microwave ablation especially when we compare with the radio frequency ablation? We do not need to hook-shaped antennas, the classical one antennas, because it is very hard to advance these shaped antennas within the lesion or perfusion needles. We can use lots of microwave antennas at once, and no need ground pass when compared with the RFA, and safe in patients with pacemaker. In patients, we can use only microwave when we compare with RFA with the patients with pacemaker. It's a safe ablation method, and no need to change the saline for the dissection. We can use we can we can easily use the saline for hydrodissection and safely lower doses of sedatives when compared with surgery and RFA. And it is an important point why we achieve a good ablation zone and good ablation area when compared with area with a shorter time, because microwaves actively and simultaneously heat all the parts of the radiation tissue with no propagation delay or inhomogeneous distribution. But RFA had propagation to greater distances mainly due to a slower thermal conduction process, depending on the physical, biological properties or the composition of the tissue. So microwave works without any dependence for the biological properties or the composition of the tissue. If it is fibrotic tissue, if it is adenomyosis tissue, it's not important for the microwave. It actively and simultaneously heats all the parts of the lesion simultaneously. So we have large and fast necrosis with microwave ablation, and we can ablate close to large vessels easily and without any damage to that, and without lower risk for heat sink effect and homogeneous coagulation necrosis due to it is feature for not dependent on the tissue consumption, and clear-cut lesion margins is another feature of the microwave ablation versus RFA. So we always discuss all the things, but as a summarize, it's a more predictable ablation zone, shorter ablation and procedure time, larger ablation volume, and lower and less susceptible heat sink effect, and less dependent or independent tissue properties. It is easily usage in pacemaker clips, and no need for ground pads needed is the main and the superiority features of microwave ablation versus RFA when compared with RFA. In microwave, in this original investigation, microwave shows more success than RFA in ex vivo breast tissue model. So it can use easily and safely use when compared with RFA. In conclusion, microwave ablation appears to be advantageous with respect to the volume of ablation and the shape of the marginal necrosis compared with RF ablation in an ex vivo bovine udder. And another original investigation about the microwave ablation, it is defined that it is a combining cell diminish where achieves for tissue across the whole range of possible composition, independent from the composition of the tissue, if it is fibroglandular or adipose contact. So microwave, if we compare with microwave with vacuum-assisted biopsy or vacuum-assisted excision, microwave has some advantages over VAD. Simultaneous treatment of multiple tumors in shorter time, post of adverse events significantly lower in microwave ablation, and lower adverse events when tumor size 2.5 more over than 2.5 centimeter, lower rate of tumor recurrence, progression, and reintervention, and higher patient satisfaction is the major advantages of microwave over vacuum-assisted biopsy or lesion excision. So if we compare the microwave ablation versus surgery, better cosmetic result, less pain, less complications is superiority of microwave ablation on surgery, but less recurrence. Of course, the existence of the lesion on surgery, so less recurrence could be achieved on surgery. But one more, in addition to this, and one more advantage of microwave is no need to use general anesthesia for the patient. So surgery has some disadvantages in general or compared with the thermal ablation methods. Breast volume loss, nipple distortion or displacement, nipple necrosis is important, very important. Poor cosmetic outcomes, scar formation and breast asymmetry are the major disadvantages of the breast surgery when compared with other thermal ablations or mechanical ablations methods. So what is the indications for the fibroadenoma ablation, especially for microwave ablation? As I said before, pathological diagnosis of benign lesions such as fibroadenoma or sclerosing adenosis or etc. We always perform a prior or initial and then biopsy for the new defined lesion. A single lesion of 30 millimeter or smaller is okay for us, but in my routine application, we exceed this 3.5 millimeters, since it is related about the ablation zone of fibroadenoma. It is so more than 3 centimeter or 3.5 centimeter, the ablation zones, especially for the peripheral part of the lesion, is a little bit lower. So we accept the patients with 3 millimeter or 3 centimeter or 3.5 centimeter or smaller. Of course, it must be breast category 3 or less, and distance from the lesion to skin and pectoralis major or the nipple muscle exceeding 10 millimeter. So it is not the first or initial examination for the 10 millimeter. So I'll discuss in future slides. We have a good tool which is hydrodissection. After hydrodissection, if we obtain the distance of 10 millimeter, the adjacent tissue, I mean the skin, pectoralis facial, pectoralis major muscle fascia, or nipple, it is okay for us to ablate the lesion. So what will you do? I'll show by some videos and the photographies. First, local anesthesia for the skin and the ablation tract. For lesion adjacent to skin, pectoralis muscle or areolar hydrodissection can be performed. We apply to all lesions routinely, actually. Under US guidance, a microwave antenna is placed in the lesion along its longitudinal axis. 30-watt energy with moving shot technique with a 17 gauge ablation antenna. 30-watt energy with continuous ablation if the lesion size smaller than 1 centimeter. Actually, we use always if the lesion is not very small, I mean the lower than 1 centimeter, we use moving shot technique such as on thyroid nodal ablation or parathyroid ablation, we use moving shaft technique. Okay, it is the example of a patient, our microwave ablation patient. You see the small lesion lower than 1 centimeter, and at the first glance, we perform an microvascular imaging of the lesions. You see the trace within the trace, 4.38% for the vascularity index of the lesion. We perform this before the ablation session and soon after the ablation session and the follow-up session. So we can easily compare the vascularity index of the lesion with a high resolution vascular imaging, microvascular imaging. And this is the shear wave elastography of the lesion. We use this before the ablation period and in the follow-up sessions in order to understand the fibrosis or fibrotic component of the lesion. So it shows a little bit technical success of the our ablation treatment, and we use it. So this is our ablation setup with a sterile surface, and you see on the left side is a hydrodissection system, which is a very simple injector with attached with a small line. And at first sight, we use or we inject the local anesthetic just to the skin and the ablation tract. Then in the same puncture site, we use the hydrodissection system with a ultrasound under the ultrasound guidance. You see just under your portion of the lesion, dissect the plans to the which adjacent for the lesions. And the posterior part. Yeah, you see the dissection. Then we prepare for the microwave antenna in order to use it. Then in this through the same puncture site, we just advance the needle to the lesion, and we puncture the lesion. You see, and we use moving shaft technique. You see, when we see soon after we see the bubbles, then we a little just take the needle back with a continuous way. You see the other side. And immediately after the treatment, we perform the some measurements and calculations and control with ultrasound. You see it is 2.75 microvascular index for the ablated lesion. It is about 50% decrease in microvascular imaging. So what are the complications for microwave ablation? Pain during or after the microwave ablation treatment, swelling and fat liquefaction and skin scalding are the most common complications for the microwave ablation. In our department, we most common or most frequent complications or the complaints from the patient side is swelling, but this is no problem for us. It will resolve within 1 or 2 weeks. In follow-up, we use always grayscale ultrasound with color Doppler and microvascular imaging software, and we use also elastography. But in routine follow-up, we do not use MRI, but in our ultrasound or color Doppler control, if we have some suspicious feature for the lesion or and not decreasing the volume of the lesion, then we can perform MRI. But we usually do not perform MRI. What is the period for the follow-up? 1 week, 1, 3, 6, 12, and 15, 60, 18 months are okay for the follow-up period after ablation. Ablation zone is expected to shrink gradually and decrease in elasticity and vascularity. You see another example of an microwave ablation for the breast fibroadenoma. It is pathologically proven fibroadenoma. You see the volume 1.11 centimeter cube before the ablation. At first week, 1.13 centimeter cube due to the aneurysm of the lesion. After 1 month, it is 0.99, about 1 centimeter cube. But after third month, you see it decreased more than twice or much, 0.52 centimeter cube for the lesion. So, what is the most high volume reduction when we achieve it? It is written on the literature about 6 months, 3 or 6 months. It is written somewhere. But in our daily routine, we realize that it is about 3 to 6 months. So in this meta-analysis, it is written over there, especially for this 3 or 6 months is okay for the major reduction in volume. It's another example for the other measurements, other parameters for our follow-up. This is the shear wave elastography. You see at the pre-op time or before the ablation, we measure as the 21.111 fibrosity index or elasticity index. But after 3 months, it equals about 53.11. So it shows us the lesion become a fibrotic one and a rough or fibrotic tissue, and the ablation is achieved by this quantitative method. And I said we use microvascular imaging for or soon after if we ablate the lesion or not, decide the ablation or not, or in follow-up images. Microvascular imaging is the more sensitive in detection of small vessels than color and power or spectral Doppler and Doppler side, reducing the need for follow-up contrast enhanced US, CT or MRI. And multiple manufacturers have some traditional names or some such as super microvascular imaging or UMA, something like that. But we use microvascular imaging both for the after ablation and the follow-up period. You see in the pre-op site or before the ablation, the vascularity index is 5.37, and after 3 months, about 0. Full ablation is achieved for this lesion. And thank you for all. This is the photography with a workshop, a special workshop in Istanbul with ECO from all over the world, the health professions or interventional radiologists from all over the world. I am very thankful to all.
ممكن افهم حاجه معلش؟
اتفضل.
طيب الساعه 18 يعني الساعه
I think the next speaker. Anybody from us? Yeah.
Hi, Maeve, please turn on your microphone.
Yeah, okay. So sorry. I just didn't open my microphone. Thanks a lot for Professor Serkin's excellent sharing. So we have learned a lot from your experience especially for the advantages of microwave ablation over the radiofrequency ablation, the vacuum-assisted biopsy, and also the surgery. And you also shared many of your cases with us. Thanks a lot. And now let's move on to Professor. Let's invite Professor Chung to sharing his presentation with us.
Good, good evening, everybody. Thanks for e-call. And today I'm honored to share with you a new technology in the treatment of adenomyosis and uterine myoma with microwave ablation. Due to its minimally invasive nature, safety profile, and fertility preservation capability, microwave is gradually becoming a viable alternative to traditional surgical option. So because I also perform HIFU surgery, so most of the topic is focused on adenomyosis by using microwave, because most of my uterine myoma is treated by HIFU surgery. So first, let's discuss the clinical manifestation and the challenges of adenomyosis and uterine myoma. Patients suffer from adenomyosis often experience prolonged menstrual bleeding, severe menstrual cramps, and significant discomfort. While hysterectomy is definitely a treatment option, it is not ideal for patients who wish to retain their uterine function or have future fertility consideration. So for this patient, microwave offers a gentle or effective alternative. So in the past, if your patient don't feel good after she took some medicine like oral pills or NSAIDs or oral diagnosis, but in then still have pain, maybe the only choice is adenomyotomy. If you have experience about this surgery, you know that it's not easy to do, because there's a normal tissue and adenomyosis tissue is not very clear between the border. So even you try to resect all the tissue as large as possible, after that maybe you sutured, but there's still massive bleeding, and your patient will recover from normal life. Maybe she need 2 or 3 weeks to recover. So I think this kind of surgery is not good choice. But they still want to discuss about this kind of surgery. So actually, the adenomyotomy have some high instance of uterine rupture because of placenta abrupta, and but adenomyotomy still have some good benefit, just like it will lower the instance of preterm premature rupture of membranes, preeclampsia, and SGA. So adenomyotomy still an option if your patient want to have a baby in the future. So we want more, and your patient want more. So if your patient want and they want symptom relief, they want decrease the adenomyosis volume. We want preserve the patient's fertility. We want do less damage to normal uterus, and they want the treatment safe and economic. So this picture of my patient. Actually, the patient received adenomyotomy 7 years ago, and the adenomyosis recurrent again, and now he decided to receive hysterectomy. I remember that I took 3 hours to perform hysterectomy by laparoscope. It's not easy to do. Luckily, I performed it without any complication, but it's still not a good experience to me. So I think that if I can use another method to treat adenomyosis, maybe we have better method. So now we have a new microwave ablation system. So what's microwave? Using an imaging guided system, we accurately place a thin microwave antenna into target tumor site. The microwave generates friction heat by agitating water molecules within the tissue, leading to coagulation necrosis. So over 1 year follow-up, we have observed that the volume of adenomas decreased about 60%, and more than 80% patients report a significant symptom relief. So it's a good method. So we can see the tip of the antenna. So this antenna, the thermal feed is heat to about 60 to 100 Celsius. So the target lesion will be destroyed. So it's a protocol by sonogram, but I didn't do that. I used laparoscopy assisted. So how microwave cure patient? Under real-time guidance and monitor the ultrasound images, the needle microwave antenna is implanted into the lesion. The heat generated by microwave radiation is used to induce coagulation, necrosis, or needle tissue in the thermal field. So the needles becomes narrow and disappears, resulting in loss of clinical symptom. Next, I will share several clinical cases to demonstrate the application and outcomes of microwave in different patient scenarios. In each case, real-time ultrasound image was used to guide the procedure precisely. This approach, combined with track planning, helped minimize post-operative complication and ensure the best possible outcome for each patient. So here's my first one. My first case is she's 42 years old, 30P0. Her diagnosis endometrioma of ovary right with deep invasive endometriosis and adenomyosis of uterus. Actually, this is my first case 3 years ago. I performed laparoscopic ovarian cystectomy right and pelvic adhesion lysis and microwave ablation of adenomyosis. So this the picture is pre-op sonogram. She has endometrioma with 3 compartment and severe endometriosis of posterior wall. After I perform ovarian cystectomy and pelvic adhesion lysis, I ablated her posterior adenomyosis. Because with my first cases, so I only ablate maybe 60% adenomyosis, but she still feel good after surgery. She's come to my clinic for 3 years for regular follow-up. She's doing well now until now. There's no recurrence until now. So this case 2, she's 43 years old, G1P1. Her diagnosis is endometrioma of ovary bilateral with deep invasive endometriosis and adenomyosis of uterus. She received a cesarean section for once and ovarian cystectomy before. And this time I performed a laparoscopic ovarian cystectomy bilateral and pelvic adhesion lysis and a microwave ablation of adenomyosis of uterus. So this is her sonogram before surgery. You can see right endometrioma and the adenomyosis. Because the patient didn't want to have a baby in the future, so after after discussion, I ablated her whole uterine her whole adenomyosis. You can see there's black region. That means the adenomyosis is all ablated by microwave. She's doing good until now. Here's my share my 3 case history. She's 37 years old, G2P2. Her diagnosis is adenomyosis of uterus and pelvic adhesion. She also has severe anemia. Her hemoglobin is only 5.8, and I performed laparoscopic pelvic adhesion lysis and microwave ablation of adenomyosis. You can see this were posterior wall adenomyosis, and there's about adhesion to the posterior surface of uterus. After I performed pelvic adhesion lysis and I ablated the posterior adenomyosis, and she's anemia is improved after surgery. Here's case 4. She's 41 years old. She G1P1. Her diagnosis is adenomyosis of uterus. So I performed laparoscopic pelvic adhesion lysis and a microwave ablation of adenomyosis of uterus. You can see the pre-op sonogram that there's a posterior adenomyosis. And this time I used a transvaginal sonogram to monitor the ablation zone. During the surgery, you can see the hyperechogenic lesion. That means ablated by microwave. So this post-operative MRI, we can see the whole adenomyosis is ablated by microwave. You can see. So the patient is well after surgery. So this is my video during my surgery. You can see during the surgery, I use transvaginal sonar to monitor the microwave ablation. We can see hyperechogenic lesion. That means coagulation necrosis. If you want to ablate the whole layer of adenomyosis, you need to make this zone expand expand to here and here as large as possible. That the result will be good after surgery. So after ablation, now I use SonoView. What's SonoView? It's a sulfur hexafluoride microbubble contrast agent. It's for intraoperative and post-operative image guidance. That SonoView enhances the ultrasound contrast by reflecting the ultrasound signal, thereby providing a clear distinction between the lesion and the surrounding normal tissue. So during the operative monitor, SonoView allow us to monitor the ablation process in real time. It helps determine whether the ablation zone covers the entire lesion, reducing the risk of residual disease or over-ablation. So actually, I also use SonoView during my HIFU surgery. You can see this normal tissue is uterine myoma ablated by HIFU surgery. So you cannot see the microbubble by SonoView. That means the myoma was ablated by HIFU surgery. So that's a good surgery. It's the same as you during the microwave surgery. You can see that. So this is a video during my surgery. You can see. Actually, the patient has received, the patient has multiple myoma. She received a robotics myomectomy several years ago, and the myoma recurred again, and she decided decided to receive microwave ablation during this surgery. You can see sono view. Another video is more clear. You can see multiple myoma is ablated by microwave. This anterior wall and posterior wall. You can see multiple myoma is ablated by microwave ablation. So, we can see this journal is this journal description discuss the protocol is just like me. They use transvaginal ultrasound and laparoscopic guided percutaneous microwave ablation for adenomyosis. So I think the result is good after 3 years follow-up. This procedure I want to emphasize is that we can, when using the transvaginal sonogram, you can see the antenna tip from here, the deep point. After that, you start the ablation. You start to the microwave ablations, and if it start, you can see the calcification gradually. And that means that the adenomyosis has a coagulation necrosis. But if you want good result, and you should make the region as large as possible, just like this. But if your patient want to preserve her fertility, you should keep this zone, and between the endometrium should be 1.5 centimeter to make their endometrium is not ablated by microwave, not have heat injury. And if your patient don't have a plan to have a baby, you should to ablate the region as large as possible. So why I use the laparoscopy to perform microwave? So because I can use laparoscopy to ablate to ablate the uterine surface by using laparoscopic. If you use a sonogram ablation, maybe you will be afraid to hit too bald. So you need to keep a safe margin about 1 or 1.5 centimeters. So I use this method to treat adenomyosis. So this review article is talking about ultrasound-guided percutaneous microwave ablation of adenomyosis. So there's no much of that. Okay. So the conclusion is that they collect 13 studies involving over 700 patients and receive sono ultrasound guided microwave ablation for adenomyosis. So the ablation rate is about 80 to 90%, and the uterine volume reduction rate is about 60%, just like HIFU. And the needles volume reduction is about 60 to 90% after 1 year follow-up. So after treatment, the patient's clinical symptoms improved. Maybe dysmenorrhea about 8 to 80%, 50 to 80%, and anemia improved respectively. And the only minor complication was observed. So I think microwave is good to treat adenomyosis. So my protocol for adenomyosis and adenomyoma by using laparoscopic guided microwave ablation is first step 1. I perform laparoscopic ovarian cystectomy, unilateral or bilateral, and electrocoagulation for pelvic endometriosis and deep invasive endometriosis. Step 2, after I perform laparoscopic guided microwave ablation, via trocar side or subarachnoid side. It depends on the lesion. So after that, doing this procedure, I use transvaginal sonal ultrasound to monitor. Step 3, I check the result by using sonoview. By doing this time, I use a transabdominal ultrasound contrast mode to make sure the ablation is good enough to treat adenomyosis. So after surgery, I will discuss the patient. Maybe she need to took some oral Dynagest or RH analog to reduce the recurrence of adenomyosis. Or sometimes we use Mirena. And I suggest the patient to receive ultrasound and check the hemoglobin and the CA 125 every 3 to 6 months. So this is my last PowerPoint. I want to tell if you want to master this technique, don't think too much, just do it. You don't have to be great to start, but you have to start to be great. As we continue to refine this technology and incorporate it into clinical practice, microwave ablation will undoubtedly become an important therapeutic option for managing adenomyosis and uterine myoma, bring new hope to many patients. Thank you for your attention.
Okay, thank you. Thank you so much. Thank you so much for Professor Chung's excellent sharing. And Professor Chung just shared his the ablation procedures and also some cases and some also valuable advice with us. And now let's move on to the second part, the discussion part. And we have